Module Overview. Respiratory and airborne precautions are critical layers in the hierarchy of infection prevention strategies, especially after the emergence of COVID-19, SARS, tuberculosis, measles, and other airborne pathogens. This module provides a comprehensive breakdown of the principles, protocols, equipment, infrastructure, behavioral practices, and legal obligations associated with respiratory and airborne infection control. Post-COVID global health standards have evolved significantly, incorporating aerosol transmission mitigation, HVAC system upgrades, mask optimization, and occupational exposure controls. This module is aligned with WHO, CDC, OSHA, ECDC, and national IPC regulations, and it equips healthcare workers and administrators with advanced knowledge and operational guidance to meet international accreditation benchmarks. Part 1. Understanding respiratory and airborne transmission. Transmission pathways, transmission type description. Examples: droplet. Large respiratory droplets greater than 5 micrometers travel short distances less than or equal to 1 meter. Influenza, RSV, COVID-19 airborne small aerosol particles less than 5 micrometers remain suspended in the air. Travel longer distances. TB, measles, chickenpox, SARS-CoV-2 under some circumstances. Aerosol generating procedures, AGPs, medical procedures that produce fine aerosols, intubation, nebulization, bronchoscopy. COVID-19 highlighted that SARS-CoV-2 may behave as an airborne pathogen, especially in closed, poorly ventilated settings or during AGPs. Part 2. Standard and transmission-based precautions. A. Standard precautions: hand hygiene, respiratory hygiene, PPE use, gloves, masks, environmental cleaning, safe waste disposal. B. Transmission-based precautions: droplet precautions, surgical masks, eye protection, patient masking. Airborne precautions: N95 respirators, negative pressure rooms, controlled ventilation. Contact precautions, as applicable, gowns, gloves. All patients with known or suspected respiratory infections require source control, for example, masks and isolation. Part 3. Respiratory protective equipment, RPE. Types of respiratory, PPE. Equipment protection level usage context, surgical mask, droplets and splashes, general respiratory precautions, N95/FFP, 2/FFP3, aerosols, airborne particles, AGPs, TB, COVID-19 suspected/confirmed elastomeric respirators, reusable, high filtration, high-risk environments powered air purifying respirator, PAPR, battery-powered, HEPA filtered operating rooms, high-risk isolation zones. Fit testing is mandatory for tight-fitting respirators, e.g. N95, FFP2. Part 4. Ventilation, filtration, and air management. Engineering controls for airborne pathogens. Negative pressure isolation rooms, AIIRs. Airflows into room, but not out. Minimum 12 air changes per hour, ACH. Exhaust air is HEPA filtered or vented outside high-efficiency particulate air. HEPA filters capture 99.97% of particles greater than or equal to 0.3 microns, essential in ICUS and post-operative wards. Ultraviolet germicidal irradiation, UVG-I, inactivates airborne microbes installed in air ducts or ceiling-mounted systems. Improved HVAC systems, ventilation with 100% outside air, smart controls to manage airflow and pressure zones, portable air cleaners, PACS, used in community health clinics, ambulances, and dental offices. Post-COVID regulations in most developed countries now mandate air quality verification, air change monitoring, and airborne pathogen risk assessments in healthcare environments. Part 5. Patient isolation, movement, and staff interaction. Patient isolation guidelines. Place suspected/confirmed airborne infectious patients in AIIRS. If unavailable, use single rooms with closed doors and portable HEPA filters. Limit patient transport. Use surgical masks during transfer staff protocols. Use respirators when entering isolation areas. Minimize entry and reduce care team size per shift. Document all entries, exits for contact tracing. Cohorting. Grouping similar infectious patients may be used when isolation rooms are unavailable. Requires strict PPE compliance. Part 6. Post-COVID, regulatory changes and best practices. Organization. Post-COVID change: WHO recognized aerosol transmission, updated ventilation guidance, CDC expanded airborne precautions during AGPs. OSHA updated PPE enforcement and respiratory protection programs, ECDC implemented. IPC checklist for all EU member states, Joint Commission TJC, mandated air quality compliance audits for accreditation. Accreditation standards now require routine HVAC system maintenance, respiratory protection training, and annual mask fit testing documentation. Part 7. Innovations in respiratory infection control. AI-powered ventilation management systems, smart wearable respirators with air quality sensors, real-time air particle monitoring, smartphone-based contact tracing and isolation alerts, antiviral coatings on masks and surfaces, learning outcomes, Module 7. By the end of this module, you will be able to understand the different transmission modes of respiratory infections, apply appropriate respiratory and airborne precautions in healthcare settings, demonstrate knowledge of RPE use, selection, and fit testing procedures, identify engineering controls used to prevent airborne transmission, align respiratory IPC practices with updated post-COVID global standards and accreditation guidelines, accreditation compliance, and CPD eligibility. This module aligns with WHO, Infection Prevention and Control Guidance, CDC, COVID-19 Airborne Transmission, Update 2021, OSHA, Respiratory Protection Standard, 29 CFR 1910.134. Joint Commission IPC Accreditation Standards, ECDC, COVID-19 Preparedness, Checklist, NHS IPC, Code of Practice. Learners completing this module are eligible for CPD units, infection control certification, and facility compliance assessment readiness.